Okay, so welcome to the Flight Conference Day 2. This is our first panel of the day. We're going to be doing our public health panel right now. So can we have our panelists just give some quick introductions?
Sure. My name is Bob Kim Farley. I'm currently serving as a professor in the Fielding School of Public Health in the departments of epidemiology, as well as community health sciences.
Hi, everyone. Veronica Flores, and I am the CEO of Community Health Councils, an organization that's been around for about 30 years. And I have a history of public health work for the past number of years.
Yeah, so thank you guys for both taking the time in this hour to kind of just share a little bit about what you guys do. But I guess one of our first questions can be can you describe just in general what responsibilities and what kind of work you do in your roles?
Yeah, okay, thank you, Robin. So as the CEO of an organization that we're currently at, as of this year now, we're at $25 million operating budget. Part of what we do is, we're a very different organization. And I think this is part of the role. From the very beginning, when we launched CHC, and Community Health Council, CHC, was the product of the 1992 uprising in South LA. So we were designed by public officials, particularly Mark Ridley Thomas at the time, and the mayor at the time, to say, South LA is an area that's quite large, that had very, if any, community health centers, had one hospital that was really functioning. And so the need for public health, right, the need for health care was extreme. So they developed this councils. Community health councils our charge was to convene public officials, to convene private and public institutions to come together and really think about how we could then populate, a community that's as large as South LA, over 1 million people, to have access, right, to healthcare and healthcare services. So that was really our launch. And so equity is at the core of what we do. And so part of my work around that is that from the very beginning, our definition of health, and this is where I felt public health is really an very interesting concept and an application, in that we from the very beginning said health is not just about health care, but it's really about public health, right? It's really about all of those elements that are part of a person's life that make it up about their health and their public, right? Public health. And so we incorporate in there land use, economic viability, healthcare, community cohesion. So there are a number of things that go into that. So part of my role as CEO of this organization is to really think broadly, right? To come to the table with an open mind about the opportunities that are available around public health, that are not limited to epidemiology, right? That are not limited to what someone that's not in the field might think of as public health. So more from a macro, from a more micro perspective, my role, of course, for the organization is, it all ends up with me. So obviously fundraising is a huge portion of it, but also management. And I think really developing young people. In fact, Allison was one of our interns that did an incredible job at CHC. And so we are very committed to working with interns and public health. So we actually, and particularly we like to focus on young people of color, and really bring them into the space and the opportunity to think independently with their research, to think independently about what it means to be in the space, and ultimately to present to us, what do you think, right? So I think that is really the space of what I manage on a daily basis.
Yeah, I think in that internship, it was just really interesting to see how many each of the interns, we were in different like teams, and like each of us had such different projects, but being able to see how they kind of all came around a cohesive idea about public health was really cool. And then how about you, Dr. Kim Farley?
Yes, thank you. Thanks very much, Veronica. Appreciated your background and what you're doing. And again, thank you for that service to the community.
Mhm.
So actually, I'm probably representing something that I sometimes teach in my classes about what is career. You can have, I think, career in depth, which people normally think about sometimes as career, that you get more and more specialized and know more and more about less and less. Or you can also have the idea of what I call a career in breadth, where you have different experiences throughout your career. And some people thrive on that variety too. And I think both are equally valid ways of going. And as I say, I've chosen the breadth. So in one sense, in answering the question, the responsibilities and the work that I have now in my role, yes, I'm currently professor in the School of Public Health here at UCLA. So I'm teaching courses. I'm teaching a course on Introduction to Public Health 10. I'm teaching a course on sometimes on contemporary issues in health, Public Health 150. I teach a graduate level course, Epidemiology 231 on principles of control of infectious diseases. And uniquely, I think, as far as I know, it's the first course ever offered at UCLA devoted entirely to happiness. I teach Public Health 10, which is happiness. What is it and how do we pursue it? So that's my current iteration of my life. Prior to this, I was with the Centers for Disease Control on loan to the World Health Organization. And so had opportunities to work at federal level with the CDC in Atlanta, an immunization program. I was then working as the regional advisor for immunization programs for Southeast Asia, located out of New Delhi for the 10 countries of that region. I then actually went to the global level and worked as the director of immunization programs for the global level in our headquarters in Geneva, Switzerland. Then went on to country level, where I was the WHO country director for India and also for Indonesia. So that was about 18 years of my life in WHO. And then also I had the opportunity most recently before coming to UCLA as director of communicable disease control and prevention for the Los Angeles County Department of Public Health, about 750 staff in areas like tuberculosis control, acute communicable disease control, like we're doing right now with COVID, the immunization program, the veterinary public health program, things like this cluster of communicable disease control. So it's been a very varied career, one that I've enjoyed very much along the way. And each step, I have to say, whether it be local, national, international, I've enjoyed. And I think each of them have different experiences that you learn and different ways that you can contribute.
Yeah, definitely. I remember us talking in that happiness class about finding your own career. And if anybody watching the recording or like is a UCLA student and wants to take a Fiat Lux, like the happiness class is definitely a really good one to take. Like we got into some really great conversations in that class and I really liked it. And then, so you guys have both now given like a little bit of a rundown on what your careers are like, but can you tell us a little bit about like maybe your educational background or like how you ended up coming to that or like what your motivations were?
Yeah, I mean, I think, my career has been very not linear, let me just say. So, part of, I think today, right, when I think about who I am in this space, I'm considered a generalist because of the choices that I made in terms of academia as well as my work. So when I first started in college, my direction was in finance. So I love economies. I really, I kind of geek out on that all the time. And so I'm like, I look at the market, that was my thing, right? So I became a stockbroker and I studied international finances. And so that's really where I wanted to be, I thought. But I'm also, one of my deep commitments, it is that I am a social activist, right? I have been an activist since the age of 14. So I was, in the early 80s is when I was in college. And so I was investing during the day in oil and all this other stuff that you have to invest in. And then in the evenings and the weekends, I was standing outside of the Shell, gas stations with my signs like, do not enter, this is the evil, right? And so I was protesting and I was investing. And that dissonance, became really hard for me. So I had to make a choice. You can't live with dissonance to that degree. So I had to make a choice. And my choice was, I cannot be in this finance space and also believe in what I believe in, right? Which the world has to change in order for Black and brown communities to really succeed in this world. And so I shifted, I pivoted at that point. So I moved from finance and I actually went into psychology in my undergrad. But in my graduate studies, then I thought, okay, then really the best way for me to do the work that I want to do is in social work. So I entered the social work program at USC. I was there for a year, but I realized also that wasn't where I needed to be, right? Because social work is a very micro level approach, right? You deal with the individual up, whereas my approach and the way that I think, it's really about systems change. And so mine is a much more macro perspective. And I had to come to terms with that. So after a year, I decided this isn't where I need to be. My parents were going crazy because here I go with another shift. But at the time, this is, I was committed. I mean, part of it was that my true commitment was social justice. That was my commitment. Education is something that I needed to do in order to achieve the goals around social justice. It wasn't that I needed to make more money. I mean, I went from being an investor that made a lot of money in my early years to making very, very, very little money. So it wasn't about that. So you have to be, for me, I wasn't driven by the money. I was driven by my passion, by my happiness. I was driven by my center, which is social justice. So when I finally went into, left social work, then it took me a moment to really, I took about a year off to really kind of think about and talk to people. Like I have mentors. That's one thing that I say to everyone, you have got to find your mentors, because people that are committed to whatever you're committed to are going to support you, right? So I have mentors that I've had for the last 30 years that I still call and say, okay, this is what's happening to me, And so I think, and I have mentors that are professional and some that are more personal. But that is what sustained me, right? So then eventually I ended up in a PhD program for organizational development, human and organizational development. And that was the light for me, because that gave me everything I needed to do to achieve my personal goals in social justice, but also gave me, sort of the space to think in this macro level. So I entered the program, and to this day, being in organizational development has made all the difference in the world for me, right? And what I needed to do. So I think part of it is, I think it was the combination of academic pieces, but also making choices that may or may not lead you, to where sometimes you want to be, but the choices are about what's in your heart, right? What makes you be a person in this world. And I also have made some changes, made changes along the way. I was in my undergrad, I was full scholarship to Occidental College. And that wasn't a good experience for me, not as a person of color. So as a person of color in those days when I was at Occidental, I really got tired of young white women telling me that I needed to go back to where I came from, that, I didn't belong, that, or someone making, oh my God, look at her accent, it's so cute. There's nothing cute about an accent. It is about who I am. Just like if somebody said, oh, that's so cute about your hair. It's like, it is who I am. I have no shame about my accent because I'm an immigrant, So, but that space was too hard. So I thought, if I really want to be successful in my studies, if I want to be successful in my career and what I want to do and not lose myself in this fight, I don't want to be here. So I left Occidental and left the scholarship and actually went into Cal State LA. And I felt that in that space, I could be me. I found a mentor immediately. At the time, Dr. Gloria Romero was there. And she became my mentor immediately when I entered. And I took all of my electives and research, because then I discovered how much I loved research. And we entered into a program, and that was at the moment that in 1992, and look at where I am at CHC. In 1992, when the verdict of Rodney King came out, all of us had our little tablets ready to go. The minute that that was announced, we were in the lobby at Cal State LA. We walked around interviewing students, and we wanted to collect data on police brutality. And so it was a really interesting time, but it was about those decisions that I made, and I was happy. I was fulfilled. I learned. I created partnerships and friendships that live today. So I think it's, again, is it linear? No, especially as a woman of color. So that's it.
Yeah, I think that totally relates to something like yesterday at one of our panels, we had a panelist mention that like for her, she went to Berkeley, but she just felt like she didn't feel comfortable there, that wasn't the right community for her, and that she ended up picking her graduate school based off where she felt like as a first-gen low-income student, where she would have the most resources and feel like she could be supported by her peers. And like she said that maybe it wasn't like Cambridge or Oxford, but it felt more right for her. And I think that you really touched on that theme.
Yeah, and then if I could just, I was a professor at USC for a bit. And when I was teaching at USC, that was my commitment to the students of color. I mean, to all students, but some of the students of color were really having a hard time. And I, just the same way that I experienced it, I was seeing that. So I think the administration was really open to having conversations with me when I would say, we need to have better programs. We need to do something different. There's got to be an initiative, like there was ways in which I could advocate for my students. And it made a difference for me and for them, I think.
So
and then we'd love to hear from you, Dr. Kim Farley.
So I think one of the things that Veronica specifically noted, and I think you can see in her discussion about this, is that the concept really, I think the simplest definition of public health is just, we're striving to achieve social justice. That really is what we're doing. That's why I think for many of us, it is a passion, it's a calling. It's not where the money is, but it is something that's really altruistic and also very fulfilling to be serving others. In terms of my own background, I mean, I think it shows in one sense, something else I do talk to students about is that sometimes doors close and others open that you don't understand at the time, but there's a wisdom behind it. And I think you'll find that probably has already happened in your lives, but certainly will in the future. So I started out actually as an electronic engineer at UC Santa Barbara. And I was planning to go in to be a PhD in biomedical engineering. However, which dates me, it was the time of the Vietnam War. I ended up with a low draft number, and although they would defer me to get my bachelor's in electronic engineering, they would not let me go on for a PhD. And so at that time, I felt like, gee, I'm getting thwarted here. I ended up then going into the U.S. Public Health Service that I didn't even know about at the time, the fulfilled military service, and it mixed engineering and public health. I was responsible in the areas of protecting the population against the hazards of electronic product radiation, like microwaves from micro-ovens, things like this. And it mixed then engineering and public health. And this is a whole new area I hadn't even thought about. And so then I got very interested in it. Actually did a year after the public health service did some volunteer work for the Baha'i Faith, primarily in Africa, and saw all the needs in public health. Children not getting vaccinations, not having access to, simple oral rehydration salts to be able to prevent deaths from diarrheal disease, things like this. So I came back to UCLA and did my master's in public health here, and then went on to UC San Francisco for medical school, and then went into the Centers for Disease Control and Prevention, where I did my preventive medicine residency, and also did a very exciting program called the Epidemic Intelligence Service, where they put you on a plane and 24 hours later you're around the world, like I was on a polio outbreak in Taiwan or diphtheria outbreak in the Yemen Arab Republic. But I wanted to mention one thing that I think also touches on what Veronica was mentioning, that, in her experience with social work, that, she realized she wanted to move beyond just the working with the individual, as important as that may be, to looking at a bit more broader perspective. And this happened to me when I was between my third and fourth year of medical school. I'd gotten married in second year. My wife and I took 1 year off, again, doing some volunteer work for a religious organization, but at the same time, spending time at places like the National Institute of Nutrition in Hyderabad in India, and the National Hospital of Western Samoa. And it was at Samoa that I was spending a month there. They had a visiting team of senior orthopedic surgeons came from the United States to help train the Samoan doctors on some of the newer orthopedic techniques. So as a medical student, they were letting me in the operating room, sewing up a little bit here or there. And I remember so clearly, one of the surgeons, senior, turned to me and he said, well, what are you planning to go into? And I said to him, well, actually, I'm planning to go into public health. He didn't say anything, went back to working on this patient. And I said, well, here it comes, here I can see this macho surgeon going to try to, put down public health. But he stopped, he looked back at me and he said, Bob, you are going to have more impact in your career than I've ever had in mine. Here we are working on this child who has polio, who should never have gotten polio to begin with. And for me, at that impressionable stage of my career, to see someone that was, again, senior, could have easily put it down, recognize the value of public health and the importance of public health. And it came back to me 20 years later when I was the head of WHO for Indonesia, I mentioned briefly to you. We actually went to 0 cases of polio. We eradicated polio in the country. I said to myself, this is what this guy prophesied 20 years ago. And the difference between working with one person one-on-one, as important again as that may be, I'm never going to have the opportunity to have the guy say, hey, doc, thanks for doing that to me. I feel so much better. I'm not going to experience a parent running up to me on the street and saying, oh, doc, I just want to thank you that my child did not get measles today. It's not going to happen. But I'm going to know myself that some of the policies and practices we put in place is exactly preventing those sorts of needless disability, suffering, and death.
Both of your guys' backgrounds are just they really show how many opportunities there are to get into the field of public health for anybody who's interested. It doesn't have to be a one-way path, you have to do this degree and this degree like it is for some other fields. You really can, if it's what you're interested in, it seems like you will be able to follow that career path.
Yeah, in fact, it's interesting today. I just had my class on Introduction to Public Health, and on occasion I have guest lecturers. I had a guest lecturer who used to work with me, Lauren Dunning, who's a public health lawyer, and talking about the power of public health law for protecting vulnerable populations and things like this. And so here again was a very interesting, there was a couple of students that was really resonating. One was planning to go to law school. Oh my goodness, I can go to law school and be in public health. So it's kind of fascinating to see all these different ways and pathways to public health.
So interesting.
Just on that, the legal aspect of it, I really appreciate that, Robert, because when this is about, I really like when you connect the social justice with public health. Once I got involved, I was doing consulting with this organization in New York. I ended up working with them, and we sued the CDC. And we won. And so it was that legal aspect of, it was a legal organization, the HIV Law Project. And I was the deputy director there. And one of the things we were seeing is that at the time when people of color, particularly Black and brown men were getting diagnosed, some of the symptoms that they were experiencing were not associated with the AIDS HIV symptoms, right? Women were having very particular symptoms that, again, were not in the list or associated with AIDS or HIV. Therefore, when they went in for benefits because they were sick, they couldn't work, or they couldn't get benefits because they were not recognized as that. So we sued the CDC, and that, you know, definitely sucked the entire organization. But we knew that, again, not one person was going to benefit, but it was going to be an entire country. So when we won, that changed the definition of symptoms around HIV and AIDS. And from then forward, nationally, men, you know, people of color, and particularly women of color, were able to get the treatments and the, you know, the benefits that they needed to get during a period of a pandemic. So, you know, so something like that, that was public health. Would those attorneys have considered themselves public health experts or public health? No, they were very much, no, we're an attorney, because I'm not an attorney, but I was a deputy director. And so I think, you know, so there's definitely that idea of like, I'm an attorney, but they did that, you know, we did that. And that changed something in this country. And so, and that's public health, you know?
Yeah, well, I think like you were kind of starting to touch on one of the other questions that we had, which was just like, what are some approaches that you've taken? Because it seems like it's not always like the straightforward answer to approaches to public health. Like what kind of topics have you tackled, or yeah, just ways you've tried to resolve issues in public health?
I'm gonna let Robert go first now.
Okay, good. Mix things up here a little bit. So I think, you know, approaches to improve public health, again, are so varied. One aspect, for example, I think has been this issue of public health law, to be able to use regulation, legislation, things like this. We had, for example, changed California law around testing for tuberculosis, because we recognize that, you know, this idea of having to test all teachers, you know, periodically was not really representing where the needs and focus should be on tuberculosis. Much more in trying to identify active cases that don't come from those sorts of routine screening. It comes from screening people in a targeted manner, where they've actually had some risks involved. So to use, you know, public health law in that fashion, I think also I recognized when, for example, when I was working with the World Health Organization at the country level, let's say in India, for example, is I didn't realize at the beginning, but then rapidly realized the importance of it, and that is WHO's power to convene a meeting. So for example, if USAID, which is the United States Agency for International Development, which is the United States, you know, arm for international aid, or JICA, which is the Japanese International Cooperation Association, their wing, if they call a meeting, there's always the idea that it's a hidden agenda here. You represent national interest. And also it makes it difficult for like Ministry of Health people to come, because, you know, you're now going to a country's embassy or something like this, you know, that takes clearances and all this. However, if WHO called the meeting, it was like a neutral flag, and we could bring all of these players together. So that then you had at the table the Ministry of Health, you know, UNICEF, United Nations Development Program, these bilateral aid agencies. And so we could discuss policies, strategies, approaches. And then when it came to implementation, people could say, hey, look, yeah, I can take that area of the country, or I can provide funds for this activity, things like this. So it became very powerful in my mind to recognize what the role could be of WHO into convening things that could then ultimately result in coordinated, cooperative activities at the country level. So those are some of the things that I recognized happen. I think the final one I might just mention is the ability to have expert advisory groups. So for example, in the World Health Organization at the global level, we had what was called the Global Advisory Group for Immunization. And so we had, there hadn't been a new vaccine put into the program since the eradication of smallpox, and they added on some of the diphtheria and tetanus and pertussis vaccines of childhood. There hadn't been a new vaccine in over 30 years, but we had some real important vaccines that have became available, that should be really made available to the developing world, and hepatitis B was one of those. And so by able to, again, convening the Global Advisory Group, discussing this as an important vaccine that may have real applicability in the developing world, and for them to make the recommendation that hepatitis B be included universally in vaccination programs around the globe, meant then that UNICEF started to buy the vaccines. Governments were trying to, make sure that their programs were absorbing this new vaccine and getting the educational campaigns out to parents, things like this. So here's again the opportunity then to use a bully pulpit of the World Health Organization with a global advisory group that provides scientific expertise and being able then to act and change the practice of global immunization.
That's pretty cool. So I'm going to bring it to today. And so some of the opportunities that have evolved that are in part in public health. So, and that, as I talked about sort of where I started with economy and looking at economic impact in communities. So one of the key aspects of our work today is around how to build a viable economic platform for communities, for people, right? And particularly looking at women. And so I wrote a paper. I started to talk about the recession in 2018. And people were like, why are you talking about recession? Nothing is coming. There's no, and I was like, no, recession is we got to get ready for recession because it's coming. I'm not going to get into how this country operates, but how we operate, we could go into recession like that. COVID gave us a really good example of that, right? So if you understand where we are economically and how the US sort of operates and its mode of operations, it could happen any moment. So when COVID happened and we went into that, it was no surprise that we would go into a recession. So in 2018, I wrote a paper about the recession, a white paper, and I distributed here and there through our networks. And then, so one of my unlikely partners that showed up is the Federal Reserve. And so they came to the table and said, we like your paper. We would like to work with you. We're going to pick 2 partners in California. Your organization would be one. How do you want to go about this? So what we did is we said, great. They only asked us not to use the word recession. So because it would impact markets. So I think the impact when they said, don't use the word recession because that could impact all markets, we're going to work on it a little bit differently. So what we did is we then came to the table, and they're one of our partners now. We came to the table and said, okay, in order to build a viable economic possibility for our communities, we have to then be able to bring in those partners that are in the private sector and the public sector. And so, really the opportunity then to work in this space, we called our first meeting in May of 2019, and it was invitation only, 100 people. And it was social impact investors. It was philanthropy, some of the people in finance, particularly banking, and the Federal Reserve and us. And, and so it was really interesting because being creative about how do we really think big? How do we really think bold, right? And then we can achieve this if we have the right partners at the table. All of that under the umbrella of public health. And so, part of what we're talking about in building non-extractive economies, that's public health. And so if we're building non-extractive economies, we're talking about creating infrastructure within communities that have been stripped. South LA is a great example of that. East LA, Echo Park. I mean, we can go anywhere where there have been what we call the gentrification. And I don't even use the term gentrification anymore because it means nothing. What it means is, are we having an extractive economy or are we having an inclusive economy, right? And so if we had an inclusive economy, gentrification becomes a different term. And so I think, that's where public health for me in this moment, now all of my experiences, that nonlinear path have come to play in my role as CEO at CHC. Is that we can work with, we work very closely. Actually, we're doing it. We just finished the study and we're going to launch it this year with UCLA. And we did a study on mothers in South LA. And so we interviewed 100 mothers Black and brown mothers to say, what would it take, right, for you to have a life that is supportive and that allows you to be the full person, go to school, get an education, take care of your kids. I'm talking about basic stuff. And it was hard, just hard to hear that for most people, $450 a month, more than what they were making, was enough to take care of their children and to make decisions about, I don't need two jobs. I can work one job and go back to school, or I can afford to go back to school. It was $450 a month. So when you think about that, it would take so little to move people out of poverty. That's public health, right? So when we think about how do we create systems with institutions that are in the public and the international and the government, how do we do that? We have a really strong partnership right now with the Department of Public Health. Actually just signed a huge contract with them, because part of what we want to do is evaluate what we're doing around public health and come up with strategies that are more sustainable strategies around how we actually have access to population health. And so there are different ways. And I think all of us, and Dr. Barbara Ferrer is actually one of the members of those 100 people that attended the convening at the Federal Reserve. So I think it's recognizing that there are people right now in positions of power who actually are public health experts.
Yeah, so what I'm kind of taking from both your response is just like the fact that public health is everywhere. Like your approach to it can really be imaginative and creative in how you choose to tackle these public health issues. And then I guess we have one final question before we kind of open it up for everyone else to ask some more questions too. But how do you think this pandemic is going to kind of influence public health in the future? Because I know like right now that is a concern. Like COVID-19 is heavily influencing public health right now, but I'm just curious to know, like, do you think it's going to change the course of the field moving forwards?
So I think a couple of things. Number one is it's already sparked a lot of interest in public health. We've had more applications to our master's and PhD programs than we ever have had. I've been serving on the admissions committee here at UCLA Fielding School of Public Health. And apparently this is not an isolated phenomenon to our school. So I think there's, it's increasing the interest in public health because people can see what public health is trying to do when we have a major global pandemic. I think also it has helped us to recognize that, we cannot assume that there's not going to be pandemics or that there's not going to be public health emergencies, that they do happen. And we have very short, sometimes, memories. And I hope that this means with this one, we'll have a little bit longer memory. By that, I mean, after 9/11 and the anthrax attacks, billions of dollars were put into public health to help strengthen public health departments for surveillance, for detecting bioterrorist events, for the creating national strategic stockpiles and also state stockpiles of vaccines or antibiotics or respirators or personal protective equipment, all of these things. But in that time since 9/11, those dollars started to shrink and shrink and shrink. And so you ended up, when we had the COVID pandemic strike, all of a sudden, the cupboard was bare, so to speak. California, for example, had developed its own strategic stockpile. And back in 2008, 2009, we had our most recent economic trouble, shall we say. California looked and said, look, we're spending $5.8 million a year just trying to maintain this, making sure the ventilators were still working, that the tents didn't have a hole in them and things like this. And so they sold or gave off the equipment. So when suddenly we had the COVID strike, there wasn't anything there. So I'm hopeful that maybe this again will make certainly a longer memory of making sure that we are prepared, that we do have stockpiles, that do have private-public partnerships in place so that when we need to make up vaccines or we need to make up personal protective equipment or things like this, that they can be done quickly and done in ways that aren't so disruptive. And I think also we've learned about the importance of unified messaging and speaking with the same voice. The disparities that existed early on with the senior levels of the administration and, let's say, CDC and others on mask use, things like this, becoming polarized politically, which basically then left people muddled, or even had people then, moving to two different camps. Conspiracy theories that COVID didn't exist, it was all made up, things like this that just made it so that we had some of these surges, like especially what I call a viral tsunami after the back-to-back holidays that we experienced. That all of that could have been avoided with people just doing some simple things of wearing masks, practicing physical distancing, as we then waited through the light at the end of the tunnel, which is the vaccines that are now coming out. But that tunnel became very, very ugly and long because of the fact that there just was not unanimity of thought and opinion and common vision as to how to do things. So I think those are some of the things that we need to look at in public health, and going forward, I think hopefully will change the face of public health and the image of public health in the nation.
Yeah, I absolutely to all of it. I think the only thing that I would add to that is that there's been a real identification of systemic racism. And I think that wasn't something that was really connected at the level that is connected now. And that public health is an element that cannot happen equitably without addressing systemic racism. And so I think that's the part for me, and for many of our partners, is that we've now put in, really have redirected how we do our work. And Allison, as you know, working with us, I think that it was a difficult time for CHC. When all of this happened, we already knew. And I think part of what's hard is that people in other communities were like, oh my God, this is horrible. And people in our communities were like, yeah, this is normal, So, and that disparity and that's a dissonance again, And so I think that for us as an organization working in public health, the only thing we did and we want to change is that when we think about public health, there's got to be some real definite metrics on how we are addressing systemic racism. That we're not just looking at classes around racism, or that we're not just, it's really addressing the fundamental issues that lead to that, right? The disparities. When we talk about social determinants of health, all of that is coming out of public health. And so social determinants of health were really the opening at the time. Now it's, we have other terms as well, but social determinants of health, it was really the opening of public health is everything around us, right? And so when we think about social determinants of health, if we don't go underneath that and say, then what is it that's leading us to that, that when we talk about upstream or downstream effect, right? That is the upstream effect. And so I think that is something that has been a little bit different. And I think as people enter academia, that there's a challenge to academia to say, there's a way in which we've been teaching students about public health, and that now there's got to be a thicker layer underneath all of it that actually talks about disparities and why we have to have public health, right? That it's all around this idea that the system has been created against us. And so when we think about a system that's created against us, that is functioning so well, there is nothing wrong with the system if that is what we expect the system to do, right? To take disadvantage and continue to disadvantage. So it is our role as public health experts and public health practitioners to take that and break it out. And as we start to break up that thick layer of understanding what it means or how from policy, and here we go now, right? It leads to the next thing around public health, which is policy. And policy is what actually could take us to the next level of breaking up that thick layer of institutional racism, that whatever we do is just, it's not even going to touch it unless we break that up. And so we can just be pawns in the scheme of public health, or we can be actual actors in breaking up the thick layer that is not allowing us to effectively engage in public health.
You know, Veronica, I think, has brought such an important point, and I think also the tools that we can bring to bear in public health, you know, epidemiology and things like, we don't just satisfy ourselves with what's the average disease rates going on in LA County, or the average vaccination status in LA County. No, public health can be a very strong weapon again to combat racial injustice by pointing out, okay, where is the disease of COVID-19? Oh my goodness, you know, it's in the people of color. It's in those who are having poorer, having lived in crowded circumstances, or have to be on the essential front lines of grocery stores or meat packing plants, things like this. And it also lets us look and be accountable for the implementation activities we do to help prevent. So who is getting the vaccine? You know, is it reaching the people who need it the most, who are most vulnerable? And so these tools that we have in public health are very important. And the final thing I'm mentioning, because it also got me thinking when Veronica was saying this, you know, another aspect of public health I think that's really important is the issue of globally sensitivity, in the sense that, yeah, we're talking more domestically here on the US, but look, you know, again, look, public health is showing, look, who's getting disease? My goodness, in India, they got 200,000 cases a day going on now with COVID-19. Who's getting the vaccines? It's not the developing world. And we know, although there's some modest approaches with COVAX and other things like this, we need to recognize we are now a global community. Viruses do not respect national boundaries. And one of the things I often think about is to almost look at the world as a human body. That, you know, as a human body, the brain cannot be saying, oh, well, you know, my foot has a sore in it, and I don't care if it gets infected, things like that, because I'm the brain, and that's the foot. No, because that foot can end up with a septicemia that, you know, spreads in the bloodstream and kills the brain, body, and all. So the same in the world community, that really we are interdependent now. And we should be caring just as much about that child in Africa as in our own families to make sure they also are protected. Because within 24 hours, you know, you can be anywhere in the world now. So until everyone is protected, no one is fully protected.
Yeah, I think that was a really great conversation that we've all had. So I think now we're just going to open it and let anybody else who has any questions to share theirs.
I guess I can go. So I have one question. Like, if you were an undergrad, what like suggestions or recommendations would you give yourself in like pursuing the path of public health?
Well, I think here at UCLA, one can certainly take advantage of the fact that we do have courses, so that you can take the Public Health 10, Introduction to Public Health 150, which is Contemporary Issues in Public Health. You can take also the introductory courses that are offered by some of the departments in the School of Public Health, Epidemiology 100, Community Health Sciences 100. All of these are possibilities. For those who have even stronger interests, you can apply for the Public Health minor that's here available at UCLA. Unfortunately, still very limited numbers. And although you won't be able to hold your breath if you're currently a student, I think within the next couple of years, we're looking very promising to actually creating a public health major here at UCLA, which will be even more opportunity. There's also a public health club here on campus that will be very interesting to join and be involved with that.
Thank you.
You know, the other thing I think that I would say as an undergrad going into public health, in addition to pursuing your courses and pursuing, like, you know, as Robert is stating, is to really find internship opportunities. I would say, you know, any way that you can be part of organizations that are actually doing the work that you want to do, right? And so I think it's almost like finding a job, really. You should be able to look for what is it that I really want to do with my life, and then Google who's doing that, right? And then when you find that, you think, okay, here's an organization or two or three that are doing stuff, and I'm going to call it stuff because it may not be so clear. You know, but you know it's something that calls your attention, especially after you know that public health is so broad. And so if there's something that calls your attention and you say, I want to learn about that, you know, volunteer, like learn and really experience the field while at the same time you're in academia and pursuing your degree. That will give you the fullest experience so that when you actually are out of academia and you graduate and you're out looking for a job, you're actually going to be in a much better position, because you're not going to be looking for a job like, okay, now I just graduated, I got to go get a job now. It's going to be more like, I understand the field, and I think I have experience. I understand what I want to do. And you can pursue all kinds of stuff. You can go into violence. You can go, I mean, there's so many interesting pieces. I mean, violence sounds horrible, but there's also so many interesting organizations that are actually working now in the space of violence. When you look at police brutality, or you look at community violence, or you look at community cohesion, you know, some of those things are key for us to have a successful society. So I would say that it's a combination of both.
Thank you.
I just have to share one thing that one time a student did that I used to teach a policy, 4 classes, but one of them was a policy class. And my first question, the first day of class would be, what do you think could be the one thing that we could do to end poverty in this country? And I had all kinds of good answers, but I had one young woman who ended up actually being one of my best students and learned a lot. It was this young white woman who stood up and said, I really think that what people need is Excel. You know, what people need is just to learn how to use Excel. So if we just provided everyone with an Excel app, and then that we taught them how to use Excel, they would be able to budget themselves, and nobody would be poor. That comes from a very privileged place, right? A very limited, right, experience place. And so, but it gives you an understanding. It gave me an understanding, like we are all at such different places. What you think is important around public health for someone else may be just epidemiology, because their experience that doesn't incorporate like, oh my God, poverty is actually a public health issue. So sharing those experiences, being in different communities, actually builds you, and you learn, right, the different perspective, because we're all different. But, you know, look at what happened with COVID. I think that's the other part with COVID. It was just, we became so much more polarized than we ever have been. And it's that lack of understanding within families, right? That lack of understanding of some of those basic principles. That's public health.
I think Caleb, you had one question, right?
Yeah, so I am currently thinking about attending medical school, and particularly matriculating in a dual MD and PH program. So I was just wondering both of your thoughts as far as a dual degree program such as this, and even besides the program, if I don't decide to take that route, what are some ways that prospective and currently practicing physicians, what are some ways that they can incorporate these public health insights and models into their daily practice?
Well, I think that
you're the right person for that.
Okay. So, there are some really excellent joint MD, MPH programs around. You should certainly be investigating those. But also, don't worry that much either if you end up not getting into one of those schools. You become a physician. There's also, just like here at UCLA, MPH programs that are tailored in the sense that those who already are physicians. So, for example, without an MD degree, it would take you only 2 years to get an MPH. With an MD degree, you can get an MPH within 1 year. So, you can always come back and do that. So I think that's one thing to realize. And I think bottom line, what public health is doing for you in as a physician or a nurse or physician assistant or almost any perspective in the healthcare is just raising the gaze from the individual to the population level. And so I think that's the power and of the perspective that public health training provides you.
I kind of have a follow-up question to that. I'm also really interested in like getting some kind of MPH or being in some kind of MPH program, and then also getting my MD, hopefully. And I was just wondering, so I've talked to quite a few people who have both MD and MPHs. Sorry, I apologize. Who have both MD and MPHs, but they've done so many different paths. So some people did it like, during their gap year, some people did MD, MPH programs, dual programs, and some people did it like in their residencies or after they became physicians. And I was just wondering, do you think that 1-year programs are like 1-year MPH programs are not as good as the 2-year? Do you think people are missing out? Do you think it'd just be worth it to do a 2-year instead at some other time, like taking the time maybe in the gap year to do 2 years or maybe later?
So I think that there's some it just depends on how the program is organized, especially if they do a full year, including the summer, as a quarter, things like this. So I think that's, just to make sure that the depth is there. That's the main thing, that you have that experience with, across different aspects and disciplines of public health, but then usually a concentration area like epidemiology or health policy and management, something like that. So I think that's one thing to take into mind. Now, I kind of did the back way around, if you will. I told you I'd had a degree in electronic engineering, which wasn't going to give me the background I needed to apply to medical school. So when I was here at UCLA, I actually did two things at the same time, getting my master's in public health, but also, doing the same things you're doing right now, I'm sure, organic chemistry and things like this, to be able to apply to medical school. I liked it in the sense because the fact that then when I went into medical school at UC San Francisco, I had already a very strong public health background. And so we created a peer education and prevention group. We did things like, I was chairperson of the American Medical Student Association International Health Committee. We had the first all medical student group go to China after the Cultural Revolution, things like this. So, you can carry that public health bent with you in medical school too, if you do it ahead of time. So that's kind of I think there's pluses and minuses to both ways. And I don't think there's any necessarily right or wrong way to do it. Sometimes it's a matter of just what actually happens to you. Maybe you don't get into medical school, but you've covered your bases by having, a master's in public health. Then you go to your master's in public health. That gives you a good foundation in which to apply to medical school, because oftentimes medical schools now don't want just people right after college. They want to see someone who has a bit more maturity and had more life experiences, and that's a good route of which to do it. Another one I just would mention, because not many people know about it, but the Center for Disease Control Prevention, CDC, does have a thing called a Public Health Apprenticeship Program, PHAP. Take a look and Google that. This is for bachelors, and they pay you and they place you in local, state, or even at the CDC in Georgia health departments. And so you get, an experience in public health. So that's another great gap. You have to apply for it sooner than, wait till the last minute. But it's a very interesting program.
Okay. Yeah. Thank you so much.
Certainly.
And we're not going to take any more of your time. So thank you so much for the panel. This was really great. Veronica just had to leave, but I'm going to stop the recording now.
Okay.